Good morning, everyone. My name is Jason Knight. I'm a physician and researcher at University of Michigan in the United States. I really appreciate the invitation from Professor Lee and team to talk to you in Beijing about antiphospholipid syndrome. I am sorry I cannot do this live, but I will share my contact information at the end so you can reach out to me with any questions. So let's talk today about antiphospholipid syndrome and my take on the past, the present, and then what to expect in the future. So you surely are familiar with the classification criteria for APS, most recently updated in 2006 with another update on the way. We have both clinical and laboratory criteria. A third to a half of these cases will be diagnosed in the context of lupus, but the remainder exist as a standalone diagnosis that we call primary APS. Patients often point out to me, though, that these criteria feel too restrictive to them, that they do not capture the full breadth of manifestations of APS. And when I think about that, I like to go to the writings of Dr. Kamashta, who has seen as many APS patients as anyone. And he points out to us all the other things that APS can do besides thrombosis and the classic type of pregnancy loss. And these include things like movement disorders and cognitive decline and heart valve damage and different cytopenias such as low platelets or hemolysis. When we look at the criteria, the other thing to note are the laboratory criteria, which I find are confusing for new doctors and trainees. And so I wanted to give a little bit of the history of how we got here with these laboratory criteria. And so this is a story that I think actually starts with syphilis. And so we can go back to the 1940s when Pangborn and colleagues learned to isolate a new type of phospholipid called cardiolipin from beef heart. Cardiolipin is very enriched in mitochondria, and so heart muscle is a great place to get a lot of cardiolipin. And soon thereafter, it was realized that this was a very effective way to screen for syphilis because syphilis patients develop antibodies against cardiolipin. And so while this was a very sensitive test for syphilis, it was not terribly specific. And so by the 50s, it was recognized that there was a common concept of the false positive syphilis test. So many infections can do this, with leprosy being a very classic one. But if you look at the non-infectious causes, it actually turns out that lupus is the most common. And so going back to the 1950s, it was recognized that lupus patients develop anti-cardiolipin antibodies. So what about this parallel story that was happening at the same time? And this one is even trickier. So this was the idea of circulating anticoagulants in lupus. And so here is, a highly cited paper from the 60s in which authors finally got brave enough to write up case series of patients that, appeared to have an anticoagulant in their system based on in vitro clotting assays. But the phenotype was actually one of thrombosis. So these were not patients who had bleeding complications, but rather patients that had blood clotting complications. And so it turns out that laboratory clotting tests contain lots of phospholipids. And so these are used as an artificial cell surface where the clotting process can begin. Antiphospholipid antibodies in this artificial setting actually prolong then clotting times by coating that surface and preventing the clotting factors from coming together. And so eventually this lab artifact was turned into a standardized test that we call the lupus anticoagulant test, which is typically done as a panel of a series of tests that can be looked at together to determine if you truly have a lupus anticoagulant. So it's a way to screen for antiphospholipid antibodies. So typically Hughes and colleagues get the most credit for putting everything together, and that was in the early 1980s when they wrote about thrombosis in lupus patients and the association with this circulating, what's now called lupus anticoagulant. And so in this study, they reported on about 60 patients. Half had a lupus anticoagulant and half did not. These were all patients with lupus. There was some association with false positive syphilis testing, and I suspect this number would be even higher if we were using modern anti-cardiolipin assays. But the strong association was with thrombosis. So, a compelling relationship between history of thrombosis and having this positive lupus anticoagulant. Also some link to abortions and low platelets and CNS disease, all things that we still associate with APS today. So a really seminal publication by Hughes' team. So by the mid-1980s, this is what we knew: the lupus anticoagulant phenotype associated with thrombosis and pregnancy loss. Patients with a positive lupus anticoagulant were also likely to have anticardiolipin antibodies, so these two often track together. However, when researchers got into the laboratory to study these antibodies and what they might be doing, what they found is if you used a purified antibody, it often failed to bind directly to phospholipids. And so this suggested that there may be cofactors in serum that are serving as a bridge between antibody and phospholipid. And so the first and best studied cofactor is one you have heard of, which is beta-2 glycoprotein 1. And so this was published by 3 groups in 1990, the Dutch group and the Japanese and the Australians. And so beta-2 glycoprotein is an abundant plasma protein. There's an idea that it exists in this quiescent circularized form, but when it finds a negatively charged phospholipid, it will open up, and in doing so, reveals a cryptic epitope in domain 1. When you have antibodies, you form clusters then of beta-2 glycoprotein on cell surfaces, and that can lead to cell activation, as we'll talk a little more about later. So cofactor number 2, I think the second best studied one is prothrombin. And this is something that has been looked at going back to the 1990s. For me, the most important paper was published by Atsumi and colleagues in the year 2000. And so what they showed us is that if you make an ELISA with prothrombin alone, it does okay. It tracks to some extent with lupus anticoagulant, but you do deal with a lot of false positives. But if you set up the assay a little bit differently, instead of coating prothrombin directly onto a plate, you coat it onto a plate that has been pre-coated with phosphatidylserine. And so now we have an antigen that is highly specific and tracks very closely with the lupus anticoagulant. And so this is a test that I think is increasingly being utilized by clinicians, and I expect that only to further increase in the future. So that's my take on the past of APS. Let's talk about the present and how we approach patients with APS. So first, approach to treatment for obstetric APS. Here's one review that I like, published in 2012. And so this is fairly well worked out what the best practices are in terms of patients receiving some combination of aspirin and low molecular weight heparin, depending on their history. If someone has never had a thrombotic event, then we typically use prophylactic doses of low molecular weight heparin. But if there is that history of thrombosis, then we would tend to use a full, I think that's obvious, but a full dose of low molecular weight heparin. And this works pretty well. I think you can tell a woman with APS that, with proper treatment, the odds of having a successful pregnancy are pretty good, probably beyond 80%. There are still, though, losses, and this is an area that needs further research for sure. So how do we approach treating thrombosis? Well, for most patients, you're going to start with heparin or low molecular weight heparin and transition that to warfarin, sometimes adding aspirin, especially in the setting of an arterial event. An exception to that is the situation of so-called catastrophic APS, where we also add immunosuppression, especially high doses of steroids and plasmapheresis to remove those antibodies as rapidly as we can. This is a topic that we wrote on a few years ago in terms of trying to dig into the evidence and see which of these pieces are the most strongly supported. For us, the use of heparin and pheresis, I think there's really good data for. Probably steroids, but the data not quite as strong there. So what about venous thrombosis? Well, if someone has had a venous thrombotic event and you know that they have persistently positive antiphospholipid antibodies, then almost everyone would recommend indefinite anticoagulation. So we know without anticoagulation, the risk of recurrence each year is going to be somewhere between 5 and 12%. And that is a risk that is typically felt to be too high to not anticoagulate. And with a history of venous thrombosis, almost everyone agrees on standard intensity warfarin, so we aim for an INR goal of 2 to 3. And this is supported by pretty good evidence, unlike a lot of the other recommendations where we don't have the randomized studies we would like to really tell us exactly what to do. And so arterial thrombosis is an example of that. Studies have typically included much less patients with arterial thrombosis, and the evidence just not super clear in terms of telling you exactly what to do. And so here's an example of that from 10 years ago when one of the APL Congress task force wrote up their report. It was felt that there was not an ability to gain a consensus that, some argued for high intensity warfarin with an INR goal of 3 to 4, and others argued for normal intensity warfarin in combination with an anti-aggregant such as aspirin. And so my observation is that in Europe, many doctors aim for that high INR. That seems to be the culture there. In North America, and this is what I do in my clinic, is, stick with a typical INR goal, but then add something like an aspirin on top of that. So what about the question of primary prevention? Another area that really more research is needed. While retrospective data suggests that aspirin is a good idea, and maybe especially in lupus patients where this has been most studied, the one-time aspirin was tested prospectively in a medium-sized trial. A difference was not seen, although in the setting of a very low event rate. So some doctors would point to the retrospective studies and give aspirin prospectively, especially if you can find other risk factors for thrombosis, such as, someone that has active lupus or someone that has a high-risk antiphospholipid antibody profile, such as triple positive APS, where anticardiolipin, anti-beta-2 glycoprotein, and lupus anticoagulant are all positive. So this is a question that's coming up more and more, and that is the question of direct oral anticoagulants. So 2 recent randomized controlled trials found increased events with the use of rivaroxaban as compared with warfarin in the comparison group. And so both of these studies included a number of high-risk patients, and one exclusively so. They focused only on the triple positive APS patients. Both included patients with a history of arterial events. And you can contrast that with a single study that did not find a signal for increased thrombosis. But this was a shorter study of just 6 months. And in this study, patients only had a history of venous events, so arterial were excluded. And it was maybe a lower risk population because anyone who had previously had a warfarin failure was not eligible for the study. So my feeling is that there may be a subgroup of APS patients with a relatively lower risk where direct oral anticoagulants might have a role, as long as the patient understands that there is some concerning evidence out there, and we still really don't have the whole story, I think. If you have a patient with a high risk profile, and especially a patient who has had a history of arterial events, then I think it's not a good idea based on the data we have to date. So now in the last 10 minutes of the talk, let's think about what we might expect for the future of APS. And so this is what I like to do. I like to think about what's coming and how we can contribute to that in my research lab. So I think one big area is better personalization. We tend to treat patients in this field reactively rather than proactively. So if someone declares that they have an arterial thrombotic event, then we get them on the right treatment for that, but it's rare that we're out in front and actually stopping that event from happening. And then I hope over time we see more immunomodulation. This is an autoimmune disease. When we treat with anticoagulants, we are masking, the downstream effect of these antibodies, but it would be nice to be able to treat things at the source. I think we would get a more holistic outcome if we could do so. So let's first talk about this idea of personalization and how might we get there. So this is a talk I gave on Valentine's Day this year when I made the point by thinking of these candy hearts, which maybe are not popular in your country, but are very popular here in the US at the time of Valentine's Day. And so the point is just there are many different APS profiles that do not look very similar to each other. And you would like to be able to approach each of these with some nuance. But we tend to, in the end, treat them as if they all look the same. And that is mainly with the anticoagulant that we already mentioned, which is warfarin. We know there are a number of adjuvant treatments that we could add on top of the warfarin. And, the hope would be maybe someday replace the warfarin with, but we just don't know which of these agents to use in which person. And so, I think one thing we need is more mechanistic trials. If we are doing a trial on APS, we need to understand, not just if the agent works, but really get the phenotyping of the patients, how their profiles are changing with treatment, to understand why these treatments are working and who they might work best for. And so one example I like is this publication by Professor Cohen. And so this was a follow-up to her RAPS trial that I mentioned earlier. And this was the relatively shorter study that did not see an increased thrombosis signal. It was a relatively more conservative population of APS patients who only had a history of venous thrombotic events. And so a little more than 100 patients were randomized to either receive rivaroxaban or warfarin. Rivaroxaban, of course, is an anti-factor 10A inhibitor. And so if you look on day 0 versus day 42, here we are looking on the y-axis at soluble membrane attack complex of the complement system. And so in warfarin, no effect. There was smoldering complement activation in the APS patients compared to normal controls that did not decrease with treatment. But you can contrast that to rivaroxaban where there was a clear difference. So patients who got this rivaroxaban, which is a protease inhibitor, had less smoldering complement activation. And so this makes you think, perhaps rivaroxaban, not the best treatment for all patients, but maybe there's a subset where it would be beneficial given its ability to negate complement activation. And here's another mechanistic trial that I like, this by Dr. Perez Sanchez and Lopez Pedrera. And so they studied ubiquinol, which is, as you know, a form of coenzyme Q10. And so they randomized patients to either ubiquinol, again, CoQ10, or placebo. And they did a number of interesting mechanistic studies. Here I'm just showing some of the relatively simpler ones. So they looked at monocyte expression of tissue factor or IL-8 or IL-6. And as compared with placebo, you can see a nice decrease in the patients that got the coenzyme Q10 and for all 3 markers. So this is an agent that seems to be neutralizing some of the background inflammation in APS. I think the other thing we need beyond the mechanistic trials and, closely related is if we have patient cohorts that we're following longitudinally, we need to get deeper with our phenotyping. We need to go beyond simply measuring the antibodies, the different types of antibodies and their levels, but find other ways that we can phenotype these patients. I think this is not from the field of APS, but rather from the field of RA, but this is a paper published earlier this year that got a lot of attention, and I think rightfully so, really interesting. So they had patients performing finger stick collection of blood at home, and with that, they were able to get weekly sampling, sampling that they could then use for whole blood transcriptomics. You could really track inflammation, in the blood of patients leading into flares. So really get a sense of how things are changing before flare. And without this weekly sampling, if you had sampling only every 6 months or once a year, you would not have been able to, ask and answer the same types of questions. Is this something that we could bring to APS? I think it would be great if we could. Here's a study that we're doing in my lab, and this was presented by Dr. Hui Shi from Shanghai, and spending a couple years with us in Michigan. This was presented at this year's American College of Rheumatology meeting as an oral presentation. And so she is looking at livedo reticularis skin to understand gene expression. We are biopsying more and more patients, and this is our very preliminary data with just a few patients so far, but already seeing some really interesting pathways upregulated, things you might expect for APS like complement activation and neutrophil degranulation. And the second phase of this work is we are pursuing single cell RNA sequencing. And we're especially interested if we can learn anything about the endothelial cells of these patients. And so direct sampling of APS endothelial cells is not something we have much data for, and we're hoping to, really add something that we think is going to be important for the literature. So that's my thoughts about personalization. We need better phenotyping. We need more mechanistic trials. The other thing that I hope is on the horizon is more immunomodulation. So can we find a way to treat APS at its source rather than masking with anticoagulants? So again, we can go back to Professor Kamashita, and I think one reason we want to go beyond anticoagulation, because all of these are things that typically do not respond. And so if someone has low platelets, you do not give them warfarin. We often see heart valve progressing despite anticoagulation, alveolar hemorrhage. So these are all parts of APS, but we just don't do much when we use anticoagulation. So how can we get, deeper into APS and treat at the source? Well, in my lab, our contribution has been more on the side of innate immunity, which we think a lot about. We're especially interested in these structures called neutrophil extracellular traps, or nets. These are webs of chromatin and antimicrobial proteins that are released by neutrophils. They are very prothrombotic when they are released into the bloodstream. And we think that they're at least part of the APS puzzle. So here is an image of some nets in the tissue culture dish. And we think anti-beta 2 antibodies and potentially other types of antiphospholipid antibodies are able to activate netosis. And once those nets are released, they are prothrombotic. So how might we modulate this? Well, one idea is colchicine, and I think we should be talking more about this drug in APS. We know that in the general population, and this was not known for so long, but published in New England Journal late last year, this study of low-dose colchicine. And so these were adult patients who had myocardial infarction within 30 days before enrollment. It was a randomized and double-blinded study where patients got a relatively low dose of colchicine, just 0.5 milligrams once daily. And then the primary endpoint was a composite of death from cardiovascular cause, cardiac arrest, myocardial infarction, or stroke. And these were hard endpoints that they were looking at. And it's very interesting to see. We can find that colchicine and placebo definitely separate. And that happens early. Within 6 months, we're seeing a separation of the two curves. And so colchicine protective in these patients, what might happen in an APS patient that's at even higher risk? I hope that someday we can find out. Another drug that we think about in my lab is one called dipridamol. The old trade name in the US is Persantine. We published a paper last year in Nature Communications where we did some preclinical work with this drug. And so the most important function of dipridamol is that it works as an adenosine transport inhibitor. And so If someone takes dipridamol, they will accumulate more adenosine on the surface of cells, and that leads to activation of adenosine receptors. We think on neutrophils, the most important receptor is the A2A receptor. And we have found that if we treat neutrophils with dipridamol, we are able to reduce netosis and other activating functions. And we have evidence that this is going through that adenosine pathway, although I'm not showing you that data. You know, based on this work that we had done in APS, we, early in the pandemic, our group was the first to report high levels of NETs in the blood of APS patients, or in COVID patients, kind of reminding us of what we had seen in APS. And so we had this idea that we were thinking to someday take to APS, and instead we took it this year to COVID. And so this is a trial that's underway at Michigan, approaching completion, I hope, as we now are having a second surge of cases. Clinical endpoints, we still don't have the data for, but here's just an example of some of the mechanistic work we're doing in the lab, where we find that patients receiving dipridamol versus those receiving placebo are likely to have higher neutrophil levels of cyclic AMP. Ginger is another one that we are working on in the lab right now, and this is a project being led by Ramadan Ali. He presented it at last year's ACR meeting, and we hope it will be published soon. And so what he has found is that 6-gingerol, which is the most abundant bioactive part of ginger supplements, really looks very similar to traditional synthetic phosphodiesterase inhibitors. And so we can increase neutrophil cyclic AMP levels by treating neutrophils with 6-gingerol. And, as expected, he's able to show that, if you stimulate neutrophils with APS IgG, you can use 6-gingerol to suppress that. And so this is something that we hope to look at in human beings sometime soon. So not something we study as much in my group, but no doubt important, is adaptive immunity. We know that antibodies come from B cells, so it makes sense in an autoantibody mediated condition if there's a way to target B cells. Over the years, using anti-CD20 antibodies such as rituximab has certainly been thought about. But the problem is that plasma cells, the cells really making the antibodies, do not express CD20. And so you do not deplete plasma cells when you use a drug like rituximab. Now, there is an interest in other fields in depleting plasma cells, and especially work done in the area of multiple myeloma with a number of drugs that go after CD38. And so this was a little paper I liked last year from Dr. Atsumi's group. And so he showed that in patients with either primary APS or lupus plus APS, that there are high levels of plasmablasts in the circulating blood. So this was an ex vivo experiment where they asked if patients' PBMCs were able to produce autoantibodies such as anticardiolipin IgG. And so they showed that if they deplete CD20 positive cells, they got some reduction, but then really a compelling reduction when they depleted the plasmablasts, which you could potentially do with an anti-CD38 agent. And so, we wonder if we're going to see more on this front in the coming years. So other drugs I think to watch, hydroxychloroquine, of course. Hopefully someone will be able to do a trial showing that it's effective in primary APS. I think belimumab, another to watch, either alone or potentially in combination with other drugs that are doing depletion. Small molecule complement inhibitors, I will be interested to see as these become more available. Anti-interferon therapies as those get rolled out for lupus. And then which supplements can we find that will be effective, whether it's CoQ10 or vitamin D or ginger or others. So thanks for taking the time to listen to me. Again, I'm sorry I could not be there live. If you have questions, you can reach out to me different ways, either on Twitter or email me, or check out our lab website to see what we are up to. You can get on our lab email list if you like, and we send out a newsletter every quarter. So thanks again for your time. And again, it's a real honor to be here.